I'm Kim Goodspeed. I am an assistant professor at UT Southwestern and been running the natural history study for the last couple of years. So thanks to the support of SLC 6A1 Connect, we were able to launch a very nice natural history study and in the middle of a pandemic, and met enrollment within 18 months of opening, which is just, I think, incredible for a rare disease. And subsequent grant proposals that we've been able to put in have really praised how involved this community is and how great the collaborations have been. So I like starting almost every talk I give with this overview of clinical research and translational research, because it brings everybody together and it reminds us, like, we all have this little part that we're playing, but it all goes back to the patient. And we're all trying to feed something into our academic work that ultimately changes lives for patients and hopefully brings treatments around. In the interest of time, I'm going to skip this slide because I think everybody in this room knows what SLC 6A1 is. And thanks to Dennis's talk earlier, I don't need to go over this slide either because he's already touched on it. So I'm going to focus more on the clinical piece, and this is really what Alyssa was just talking about. Like, it's a multifaceted disorder, but it arose really out of epilepsy journals and out of epilepsy clinics, and so there was a ton of focus on the seizures, and I'll show a couple of slides just in reminding where we've been of kind of how the seizures have been described previously. But we now know that it touches all aspects of life for these kids, and some we can describe and we have words and diagnoses that we can label it. But other things like the motor impairment, it's harder for us to describe it. The kids are a little more clumsy than their peers. They don't move as smoothly. Maybe we can use a word apraxia, but what does that even really mean? If you get 5 neurologists in the room, we're all going to describe it slightly differently. And even talking about things like tremor or dyskinesias, again, you could get 5 movement disorders, and I have asked a bunch of movement disorders to look at the videos, and everybody uses different words to describe it. So I think that's pretty tricky. And then we think about behavioral problems, and sometimes it's ADHD, sometimes it's aggression, like we heard from Ms. Herbert earlier. And so then autism is also this huge umbrella term that means a lot of different things. And if you've seen one kid with autism, you've seen one kid with autism. So we have good words to describe certain things and tricky kind of gray areas that we're trying to wrap our heads around still. And then when we think about treatments, when I'm in clinic with families, most of my kids in clinic have autism or intellectual disability, and then a lot of my kids have a genetic etiology for those conditions. And I can't tell you how many times I've said, I have nothing to treat your disorder, but I have a lot of different things we can do to help with the symptoms. And so we can make life a little bit better, but we can't really get at it. And we're piecemealing so many different things together. And a lot of these kids with SLC 6A1 in particular end up on really complicated polypharmacy regimens. And then you're not sure, well, is that a side effect? Is that an interaction? Or is it something actually working? Or is it the disorder itself? So this is how we have looked at structuring the clinical side of the SLC 6A1 research program. So patient registries like Citizen, like Simons. We also have a registry that we can enroll and control some of that data, and it's got a lot of crosstalk between all the other registries that are out there. Then there is our retrospective cohort study that we did and got published a couple years ago. We have our prospective study that's ongoing. So we've got 20 kids enrolled that we're following annually with EEGs and clinical exams for about 5 years. We're in year 3 of that study, and that's also part of our biomarker study. So looking back where we've been, I've presented this before, but the first paper we all put together was the one looking back at all of the published cases and then some of the other reported cases that maybe hadn't made it to the literature yet. And we discovered that myoclonic atonic epilepsy was not really the most prevalent seizure type. That's the most common seizure type, I think, if I can anecdotally say, where kids get diagnosed with epilepsy, but by far, absence or atypical absence seizures seem to be the most prevalent seizure type, which when we think about clinical outcomes is tricky because those are harder to count than your drops. And I would argue, after watching lots and lots of videos of kids fall with SLC6A1, I think their drops are harder to count than other kids with atonic epilepsy. I'm kind of looking at my epilepsy colleagues over there, and they got a thumbs up. I think they're more subtle than the drops that we're classically taught are drop seizures. So I do think seizure outcomes are important, but I think they're going to be really hard to measure and harder to measure in this disorder than they are in other conditions. So I've laid that out there again. What was nice, though, also in this bottom left-hand corner is you can see the power of a registry study. So like I said, most of the early cases were described by epileptologists who are interested in seizures and EEGs and all of the things that go into epilepsy. And they may not have been publishing about movement disorders and apraxia and hypotonia, because almost all of our kids with genetic developmental delay have hypotonia, so we often don't put that into a manuscript. So when you have a registry study where everybody gets asked the same thing, you get a lot more uniform data, which is really nice to be able to use. And then prospectively, you get to actually say what we're going to capture and what we're going to look at. So one thing that has been striking as we've gone through this natural history study is it feels like there's a spectrum at least. And so we've dichotomized it now into mild and severe. This is not a validated model. This is not the end-all be-all definition of mild versus severe in SLC6A1, but this is our initial attempt to say, can we put a marker down and say, this is how we're going to define mild, this is how we're going to define severe, and track that and see if it plays out. It may be that it's much more of a full-bodied spectrum as opposed to bimodal distributions, but we will see. So if we apply this definition, again, a working definition, to our cohort, it's roughly 50-50. I know I said I have 20. We have 20 in the natural history study, but we've seen around 35 kids in total clinically. And so the age differentiation is not terribly different. It's pretty evenly distributed among sexes. But what you start to see is that the kids with a more severe profile or meeting this more severe definition tend to have more intractable epilepsy, tend to have more severe developmental delay, tend to have more severe autism, and also more insomnia, which we defined as needing medication. So we'll see, but this is what I'm proposing that we'll kind of use going forward to test. Can we see that outcome measures look different between the two different groups, which may ultimately help us as we're thinking about structuring future clinical trials. Can you bucket them and use slightly different outcomes or endpoints for those? So thinking about endpoints, I've shown this slide before at prior symposia, but essentially bucketing them into biomarkers on the left, so things that we can measure and quantitate but may not have a functional or clinical meaning to them, and then functional outcome measures or performance measures. These are things like all the surveys we make the parents fill out or the psychometric testing. And then hopefully you can have some crosstalk between the two to show that your EEG looks different based on different clinical endpoints as well, and that you get to tell a nice story. So thinking about patient-centered clinical trial development. The SLC6A1 Connect community partnered with a company called Trend Community, and this is a group that does predominantly social media listening is what we did on this project with them, where they took a period of time on Facebook and used some AI algorithms and natural language processing to pull out what are those topics that families are discussing. And we were able to get this published this year, and it helped us to show and look back over our retrospective data as well to say, these are the kind of key concepts that seem to be important for SLC6A1. So a lot of it is neurologic disability, a lot of it is developmental disability, and then there's a few other smaller pieces of the pie that could be important to measure. And so we have a draft disease concept model here, and this is where we can lay out and say, these are all the symptoms that families seem to care about and we seem to be able to identify in our patient populations. And then we can map our clinical endpoints to these different domains to say we're measuring, for example, self-care and daily living skills using this tool. We're measuring socialization using this tool. And then it justifies to the FDA or other regulatory bodies why you're picking the different endpoints that you are. So now going forward, we have an ongoing qualitative research study where I have some of my trainees doing structured interviews and developing and fleshing this out into a full-blown disease concept model. We have some prelim data on our quality of life assessments that we submitted, and unfortunately just wasn't as well received as we'd hoped by the paper, but Hamza really did this work with me and used a bootstrapping technique to oversample the data and start to build out kind of confidence intervals where we can say, you know, patients have different discrete levels of quality of life scores, and then can we go back and look at the different patients and say, oh, these particular clinical symptoms tend to have these level of scores. So maybe our severe group patients have more severe quality of life scores as well. And so we can start to map these out and put clinical meaning behind these confidence intervals. We used a couple of different measures, and we're still collecting this data. QI disability, the PEDS QL family impact module, as well as the quality of life and childhood epilepsy questionnaire. And the QI disability actually, I think, worked probably the best of the three. And anecdotal feedback from families, they feel like they liked that one the best in terms of like answering the questions and feeling seen and resonant with the questions. And that one actually had the best kind of differentiation between the confidence intervals. However, we also had more data because we had Simon's data that we could pull into this as well. There are undoubtedly duplicate patients in this, right? Because it's a bootstrapping methodology. So this is the prelim entryway into this, but showing some nice promise. Getting at that movement disorder piece, maybe we can't agree on what to call it with a name, but can we give it a number? And so we have the developmental coordination questionnaire, and this questionnaire, it has a very broad range on what is considered potentially clinically significant or consistent with developmental coordination disorder, but lower scores tend to be more consistent with that concern as opposed to higher scores. And pretty much across the board, these kiddos tend to have lower scores that fall within the range for their age of a DCD diagnosis. I don't care as much about diagnosing DCD, but I do care that this is a measure that, again, families are like, oh yeah, these are the things he can't do, and now we've got measures that are not necessarily validated in this population, but we're seeing that it's consistent with what families are describing. And then sleep disorders. So lots and lots of behavioral, predominantly sleep issues. Trouble falling asleep, trouble staying asleep, and lots of restless sleep described. Not as much in the way of OSA or obstructive sleep apnea or things like that, but lots of rigidity around they have to have the exact same bedtime routine in order to maintain sleep. And sleep is one of those outcomes that affects the entire household. So it can affect the well-being of the other kids in the house as well as the parents and their ability to contribute to society and go to work and do all of their things as well. So we're using a couple of different sleep measures. I only reported out the SDSC. I was having trouble with the calculations. I think there's something with our REDCap that we need to look at for the other one that we were using. But this SDSC was really nice, actually. Total scores were predominantly all within the range of having a sleep problem, and almost all of our kids reported some degree of sleep issues. And then this middle graph shows that it's really not those sleep-related, breathing-related sleep issues. It's really those more behavioral-related sleep issues that are coming out as kind of the prevalent high scores on the different subdomains. Okay, so I have 5 minutes to go through our EEGs. I will do this quickly. So I'm going to skip over this for this audience, but when we started this study, my epileptologist called and said, these kids' EEGs look a lot like Angelman EEGs, and I was thrilled because I already knew that Delta Power was something that Angelman had used, And if we knew that they have rhythmic delta similar to what Angelman syndrome has been shown to have on their EEGs, then maybe we can apply those same methodologies for which there is some precedent to our analyses. So if I can convince you, the top EEG is from a historical Angelman paper, one of the first describing their EEGs. This is actually predating their genetic testing for Angelman, but nonetheless, the bottom is a screenshot from one of our SLC6A1 EEGs, and you can appreciate that rhythmic delta, so the burst of that slow wave activity that looks pretty, each wave looks similar to each other, is what really pops out at you. This is also a sort of epileptic phenomenon that can be linked with absence epilepsy, so the story all starts to fit nicely. What they've done in Angelman syndrome, I'm going to blow past this, but you can do power spectral analyses to look at how much is that delta activity contributing to the overall picture of the EEG. And in Angelman syndrome, they've shown that higher delta power correlates with an earlier onset of epilepsy, as well as lower performance on, or lower scores on their cognitive testing and motor and communication scales. And there's also been some genotype-phenotype correlations done with delta power as well. So it's a fairly robust biomarker. May or may not be accepted at the FDA just yet, but it's a fairly robust biomarker. And it can respond to treatment. So this was a post hoc analysis of a clinical trial. So this was not part of the initial study design. But when they looked back at the data, they saw that in a trial of minocycline, I'm not proposing that we treat kids with minocycline, I'm just using it as an illustrative example, that they looked at the EEGs and they did tend to get better. And that rhythmic delta pattern goes away and the delta power goes down over the course of treatment. And that's not terribly dissimilar from the open label prelim data that we've seen come out of Dr. Grinspan and Demarest's study with Ravicti. So we looked at EEGs. So similar to the Kaplan-Meier curve that Ellie showed us just a minute ago, their EEGs tend to turn abnormal, if you want to call it that, by the age of 3. So half of the kids by age 3 will have an abnormal EEG. Prior to that, it's a smaller percentage of the population. But by age 7 or 8, almost all of them have an abnormal EEG. So I do think that there is some precedent to kind of keep chasing down this EEG biomarker pathway. And we've done some prelim analyses, just looking at the group, not dividing them necessarily into severe or mild or any other fancy segregation. And we have a small population of just 20. But if we look at the EEGs we've collected through the natural history study, this is data from time point 1, which predated the onset of, or opening of the Ravicti clinical trial. So these are all kids who were not treated with Ravicti. The delta power on the graph on the right goes up with age. So the kids with SLC6A1 are in red, and a matched, age-matched healthy control, or typically developing control. These were kids that had been in our system, had gotten an EEG for some clinical indication, but had no other neurologic disability on chart review and had a normal study. Their delta power tends to go down. So we're starting to see some separation there at least. A lot more work to do, but again, promising initial data. And then this is super pilot data, but we are doing an MRS biomarker study as well, so we can measure GABA using a special technique that my collaborators at our UT Southwestern Imaging Center have developed that is a cleaner way to look at GABA, I think is the easiest way I can describe it, and it's less sensitive to motion degradation. So the kids are not sedated for these scans. We have scanned, I believe, 4 or 5 kids with SLC6A1 and 2 typically developing controls, and we have really clean data from those kids. It's too early days to actually analyze and see if there's differences, but we're actually getting clean data. So really exciting, and we really appreciate the families that are going with us on that journey. It's not easy to put a non-sedated kid with SLC6A1 into a spaceship that makes a lot of noise. So next steps, we're going to keep collecting data. I'm always open to collaborations, and I'm always open to ideas from y'all or from our patient community if we need to do something different or look at something in a different way. And a huge thanks to our whole team. I didn't spell everybody out, but I made it right on time.